Hi, everyone. We're getting ready to start in just a minute, so we'll be right with you. And yes, we are under a lot of pressure. All right, well, why don't we get started? I want to thank everyone for attending today's session. This is being hosted by the Compliance Committee of the New York State Chapter, and we have the 21st Century Cures Act final review overview, the health data interoperability and applicability. Helen Figge is our facilitator, so we're very, very excited to have a dynamic panel today. Just some quick logistics. If you're looking for closed captioning, there's a CC button on the screen. You can click it and you can actually get closed captioning. Questions and answers, we're going to entertain that through the chat function, which you'll see the little question mark on the right-hand side of your screen. Just put your questions in there. We'll take them later on in the presentation. If you're running any technical difficulties, I would suggest just refreshing your web browser. And this event is being recorded and will be available within 1 week on our website and also on our YouTube channel. If you'd like to become a member of the HIMSS and HIMSS chapter, here's our 2 links where you can get more information about that. And we actually provided a scan. So if you have your phone out and you want to do a quick scan of that, it'll get you right into our site and our membership. And now, without further ado, Helen, I believe we're going to turn it over to you. So I welcome today's presentation. Helen, take it away.
Thank you, Nick, and welcome everyone on behalf of the HIMSS New York State Board and all of our chapter members. We're very excited about this first ever compliance webinar. I want to give a special thanks to the New York State HIMSS Compliance Committee, Terry Couch, who is the Vice President of Clinical Systems and Epic Applications Program at Guthrie Clinic, Nancy Levitt, who's the Director of Business Applications at St. Joseph's, Sean Eager, who is a social worker for the state of New York and an adjunct professor, as well as Azmat and myself. What I'd like to do is to introduce the panel now, and really they'll be able to share their perspectives on the final rule, specifically on the compliance to the interoperability provisions, followed by a discussion that we welcome everyone to engage in. Chuck Fennell, who is the Regional CIO of Trinity Health. He also oversees St. Joseph's in Syracuse, as well as St. Peter's partner here in Albany. Azmat Ahmad is the Director at Large, and she is my co-chair for the Compliance Committee. Mike O'Neill, who is the Chair of Technology for Health 2.0 Boston chapter and also the CEO of MedicaSoft. And Jennifer Busey, who is the Director of Data Exchange at Albany Medical Center. I think we really would like to get this conversation going, and Azmat is going to provide a brief background on the 21st Century Cures Act, the final rules, its impact on the stakeholders, and on healthcare information. So, Azmat.
Certainly, thank you, Helen. Good afternoon, everyone. It's good to be here with friends and colleagues. I'm going to set the stage a little bit, as Helen said, in providing a background on the final rule, a few of its components, what it means. Just so that everyone's aware, we do have a slide at the end of the presentation where there are links to specific information. We are not necessarily going to cover the timeline per se and get into many of the details and the minutiae of the final rule. You can access all of those through those links. There's also a recent webinar that Jen had shared, which we have also provided here, so thank you to our guests for doing that. So as we begin, the 21st Century Cures Act was signed into law in late 2016. Remarkably, it was a bipartisan effort, and it is still commented on in terms of the kind of support that it received from our legislature. So it had many components. It had funding for the National Institute of Health. It also had areas and elements that were promoting pediatric care, as well as standards for medical devices, etc. The piece that we are going to be focused on is the Cures Act final rule, which was published on May 1st of last year. It implements the interoperability requirements that were outlined in the Cures Act. So for those of you who would like to get rather specific at and look and examine the text itself, this is Title 5, the delivery portion, specifically sections 4001 through section 4006. Let's go on to the next slide, please, Nick. Thank you. So what is it about? The final rule and its purpose really puts patients at the center of care. That was the intent. Patient control and patient access. And how does one get to that? So therefore, it had three sections in which three areas that were addressed. One were requirements for the EHR, the electronic health record systems. The second was interoperability, and the third was information blocking. In each of those areas, obviously a number of stakeholders in the healthcare information technology arena are impacted, particularly patients, because by the utilization of these standards, they would have easy and the right to access their charts. Anytime we talk about access, you all know in technology, we have to talk about patient privacy and security. That's another element. And the second part of it is control. How does one go about providing patients choice and control as they shop for care? What it means for physicians and hospitals, the intent is to make the patient's chart and the data in the patient's chart easily and readily accessible, to be inexpensive, actually down to zero if possible. It would also allow choice in software, so restrict and open up the market so that there would be more ability to utilize different pieces and parts of software. Obviously, all of this leading to better patient safety. These rules and standards would be put in place by health IT developers, and I know Mike is going to talk about some of the requirements there with regard to fire standards and so forth. And in general, putting these standards together, enhancing and maximizing innovation is really what the aim of the final rule is. Nick, if we could go to the next slide, please. A little bit of background about information blocking. In previous requirements, for those of you who are familiar with meaningful use requirements, which later became promoting interoperability programs and so forth, the major concern for providers and provider organizations were with regard to implementing certified electronic health records. Obviously, some of the policies and procedures that went with that. However, in this case, information blocking is not so much focused on the technology as the information itself, and the fact that patients have the right to their information. So a key date to keep in mind is April 5th, when this becomes a mandate. And at that point, any and all of the actors as defined in this act, meaning providers, healthcare IT developers, organizations, payers, cannot be information blockers, meaning that a certain set of information must be provided to patients, and this information is defined as electronic health information. It's defined in the Act, and there are certain provisions with regard to that. Excuse my phone ringing here for a moment. There are exceptions that have also been provided, and we'll talk a little bit about how to deal with these exceptions. However, the major focus here that we need to maintain is on processes and on the education of our team members such that they know that information must be readily accessible to patients. We need to examine all of those processes for intake as well as output to ensure that that standard is being met. On to the next slide, please. A little bit about advancing interoperability and that portion of our final act here. Here, the final rule clarifies a standard that is going to be set up for APIs. The FHIR standard release 4. The APIs being of two types, one directed to individual patient record and a second directed to population records or aggregated records. These provisions would allow patients to use these APIs to download their health data onto their applications of choice. These provisions also reinforce the original intent of HIPAA. So if we all remember, very often HIPAA can be utilized or thought of as code with regard to privacy and security, but the P in HIPAA really does stand for portability. And so that portability portion of HIPAA is reinforced by the provisions of the advancing interoperability provisions here. So with that, Helen, I'll hand it over back to you.
Thanks, Azmat. You know, there's an unprecedented amount of access now to patients' data, and we're going to be seeing this more and more, and it's a challenge not only for the patients to receive and understand it, but also the providers who have to handle this data. And it's exciting to hear Chuck's perspective overseeing Trinity's health systems here in the East Coast. So Chuck, please share your thoughts on the consumer and what you're seeing.
Sure, thanks, Helen. So there are a number of important provisions in the final ruling that Azmat had gone through, but access to data through the required APIs are likely the most relevant to patients and potentially to health systems, right? So the API provisions will grant patients the right to access their health information at no cost through using a third-party app of their choice. So we as healthcare providers have limited ability to interfere or deny or block, as Ahmad had mentioned, that access or really have any control over the downstream use of that electronic information. So the provision has the potential to truly shift the perspective of who owns or manages a patient's health information. And if we take a look back, and I remember the days, but when meaningful use was first coming out, we did a great job in implementing patient portals and websites. And I'm sure many of you and many of us have MyChart accounts or similar types of accounts today to gain access to our information. But unless a patient receives their care exclusively from a single health system that maintains all of their services and programs in a single integrated platform with a single patient portal, patients, I'll say, will struggle getting and assembling a cohesive picture of their health. And as we also know, it's not uncommon for even single health systems to have multiple portals that patients have to register and navigate their way through, which causes us to question what will be the role of our branded patient portals in the future as patients can now download their EHI, their health information, into their app of their choice. Patients are no longer going to be reliant on us or a health system to decide what health information they should see and when they should see it. And now armed with their own healthcare information, patients have a greater degree of control. They can be brand agnostic. They no longer are tied to a health system or to a health system's portal for access to that information. From a clinical perspective, thinking of a more informed and more empowered patient and how that will change the way clinicians talk about that patient's conditions. So knowing that patients will have access to their clinical notes and the immediate release of tests and studies clinicians are going to have to think about and be more upfront about a patient's conditions and what to expect before ordering those, and helping the patient understand the potential outcomes before a biopsy or an MRI could potentially cause some unnecessary concern or downstream misunderstanding when those results are released to the patient. I also think we'll see some consumer-focused technology companies entering into the healthcare market, even more than what we've seen today. So reinventing the way and the different methodologies that patients can view and interpret their data, far beyond what we've been able to provide through our traditional portals. That could be perceived even as a threat to healthcare providers, right? So us. So as a consumer, if I can view all of my healthcare information in Apple Health versus my, my Epic MyChart portal or whatever, and that is my trusted source, where is our healthcare branding or our healthcare association for that particular patient? And we'll also likely see more disease and condition-specific applications that offer patients much greater insight and access to services such as education, progression metrics, and community support. So, for example, a diabetic that's looking to stay in shape can choose an app that integrates his or her fitness data with glucometer readings and lab results all in the same place. And who knows, it may be common at some point in the future where we may see physicians actually prescribing apps to patients. And then I'll say lastly, there is some market differentiation opportunities, at least I feel, in connecting this new world for our patients. So how do we educate patients on the use of this data, the good and the potentially harmful implications, as well as larger health systems and their potential to create their own apps to gain that patient's attention and loyalty, and likely more importantly, to support their well-being. So I think I'll pause there and turn it back over to you, Helen.
Chuck, so let me pose this thought to you. So you're saying that potentially a patient, the healthcare consumer, would be able to get their data before the physician or clinician who ordered the test would be able to review it. So is there a potential there that we have to pre-educate prior to ordering any test to ensure that A, the workflow for the clinician doesn't become so burdensome that they're stopping to answer calls, or B, to ensure that the patient is not over anxious about a test that otherwise would be normal? Can you expound on that a little bit more?
Yeah, I think, I think there's different requirements and timings associated with releasing of results. And it's getting more and more real time. And there are health systems and movements that are looking to make that in absolute real time. But part of the final ruling has very defined and very prescribed timing around when those results will be released. And for those providers and those clinicians that aren't preparing patients for those results or not getting back to those patients in a timely manner in which those results will be released, may be causing some unnecessary concern on behalf of the patient. And you can imagine the test result that may come back, or the scan or the biopsy, where a patient is reading that or downloading that information prior to that being interpreted and communicating them on behalf of the provider.
And have you seen anything, given the COVID pandemic, do you see a little bit more energy on this topic of results in real time, or has the pandemic not really changed the energy around this?
I don't think COVID is really, the COVID response has really changed that. I think obviously access to COVID test results, I mean, people want that immediacy in that, but I don't think that's had a big impact on this. I think this movement has been started, since the open notes and other movements prior to that, and the final provision or final ruling really just, I'll say, creates an even playing field across all providers.
Has Trinity changed any of its policies given this new need for data at the consumer's fingertips. Have you reacted or proactively?
Yes, certainly the education on behalf of the providers and what the final ruling implies in terms of patients and what their capabilities are. I think it'll be interesting to see what the uptick is in terms of patients using that API to download their health information. The St. Joseph's in Syracuse and St. Peter's in Albany, we've already enabled those APIs. Not a whole lot of usage, but I think as more and more patients get educated around what the final Rules Act is, I think we'll see an uptick in that usage, and then the obvious implications associated with that.
Thanks, Chuck, so much. Fantastic. So let's change it a little bit, and now we're going to turn to all the technology that's going to really be required to create this positive wave of data. So I want to turn it over to Mike. Mike, if you can give us some and all of the underpinnings that we're encountering in healthcare, and also, proactively how people can address all of these issues.
Sure, thanks, Helen. Well, as we've heard from Azmat and from Chuck in talking about some of the goals and objectives and really the use cases, the user model that the rules are introducing here, we've already heard references to technology, to APIs, and in particular to FHIR. And actually, the final rule that we're speaking about here is much more prescriptive than some of the earlier rules under high tech and meaningful use, where over the years, for anybody who's tracked this or been involved, the notion of an API is not new. It was mentioned, but it was mentioned in I would say in a softer way as a preferred option or as a directional statement. Now in both the ONC final rule and the CMS final interoperability rule, it's very prescriptive. Not only must the API be FHIR, it must be release 4. And excuse me, and in fact, it's prescriptive on what data elements you have to make available via the FHIR API, the US CDI data set. So that's good news in a lot of ways, because if we're going to have technologies that work as smoothly as Chuck just mentioned in some of his use cases, we really, as a whole industry, have to agree on not just a general direction to APIs, but what API we have to be able to make those connections. In fact, it had gotten to the point where it almost sounds in a lot of discussions, I will admit I'm guilty of this myself sometimes, that you have a picture like we're showing here. It's as simple as this. Hey, on one side, we have all this data that we know we want to use. On the other, we have all of these people, patients, providers, the payer community, they want to use it. What's the answer? Well, just drop FHIR in the middle and it just solves everything. Obviously, we know that's not true. And for those of us in the community who are involved in the technology aspect, I think we have a little bit of a flavor for what does it mean before you drop that FHIR icon in there and start making clever puns about everything being on fire. So Nick, maybe if we advance to the next slide. This is, of course, I'll say right from the beginning, this is still operating one level below the FHIR icon. We're still talking about PowerPoint architecture here. But the intent is to show just at a very high level what general types of systems are we talking about if we're going to drop a FHIR API in there. You can also think of it this way. This could be a simple, very simple representation of, let's say, your EMR. I think Chuck mentioned that he's enabled APIs on EMRs, for example. But this can also be an HIE, a state-level HIE that's organizing data and exposing it via FHIR API. No matter what type of system you're dealing with, you basically are collecting a variety of data. In the EHR case, it could be what is coming through your EMR during encounters and so forth, and getting recorded as the patient record, and that's the data that you're looking to share or to expose, as we say in API terms. But it can get, of course, much more complicated from there. You may need to pull data from multiple, otherwise unconnected EMR systems. You may be incorporating data from the patient, social determinants of health. You might be incorporating claims data from the payer world with clinical data. All of those things can be kind of implied by some of the use cases that we've heard about so far, and I'm sure we'll hear about as the hour goes on. So under the covers, under that FHIR API there that we're showing, there are some real questions that from a technology point of view, you have to understand about what is the data that I'm trying to aggregate, to collect? How am I going to do that? How am I mapping that to this FHIR standard? Most systems don't use FHIR as their data model, as the way they organize data today. So there's some steps to convert or map that data to the FHIR standard. When all of that is done, then you can start to expose or make that data available to the patient application, as Chuck mentioned, to other providers via API exchange or in the payer community. Maybe let's, Nick, if we can advance one more slide. So if we undertake an implementation or making available a FHIR API, as we showed on that previous slide, are we done? And actually, as I've said here on the slide, it's not so much a question of, am I done? I've got an API. It's more, what did I just sign up for? All of the use cases and the workflows that Azmat and Chuck have mentioned so far involve more than just data being available via an API. Everything from a provider point of view, if you're going to make clinical data available via an API. For CMS interop rules, if you're making patients' claims data and encounter data available, you're really supposed to make it available to the application of their choice, yes, and at no cost and so forth. Right away, you have a question of what applications am I going to support? How is that going to work? Do I, as a provider or a payer, do I need to get involved in some level of certification of applications that I say these will work with my system, with my data? If that is a step that you consider, are you really taking a few steps towards supporting your own app store where patients can come and say, you can use anything you like, but these I know work well, some flavor of this? The rule is not prescriptive at this level, other than it's pretty clear, both in letter and spirit, that the intent is to not constrain patients, to not put a burden of cost or limit their choice. But there really isn't anything spelled out to say, here's how you do this. Here's how you as a provider even limit your own exposure to user support kind of questions of people who say, I'm supposed to be able to get this app to work and it's not working. You know, this is a world we just may not be used to living in. So there's a number of technology-related factors that really enable the smooth operation, smooth execution of the use cases that we've mentioned. In fact, I just said et cetera because I'm sure all of you can think of more that I'm not mentioning here, including things like patient consent. If we are talking about patients accessing their data, that's one thing. But if we're talking about giving access to other providers or payers to data, how are we factoring in the fact that patients have the right to exercise consent and that there may be state level rules on allowing access and so forth? All of these things are factors that end up adding technical complexity to that FHIR API. And I think if we look even beyond getting individual patient access to data, if we can envision APIs really being used for more bulk data exchange or start to replace the kind of electronic exchange we do today that's really document-based. Let's say if you're connected as a provider to a national network, to eHealth Exchange or Commonwealth, something like this, you can see some point down the road where instead of exchanging documents, you might retrieve or push or provide just the data elements that are of interest via API. Another great thing, it works very well, on my whiteboard. Every time I draw it, that drawing works great. In real life, this is something that has real technology implications. Everything from protecting security and privacy, which gets into things like authentication and authorization, but just the raw system performance, a system that was maybe originally not designed to do a high volume of API-based exchange, may suddenly be in a position where that traffic is measurable and is impactful. So there's a lot of different system planning elements that come into play when you start to take a few steps down the API roadmap. Why don't, Helen, I wrap it up there, turn it back to you.
Mike, so if you could, from a simple thought process to apply data to FHIR standards, everybody throws around FHIR standards and everybody seems to say they support it. If you could you give the audience a few pearls of what to look for when they are required to have FHIR 4 standards and think they have it when in fact they don't, given the significant impact and the requirement for that? Is that?
Sure. Yeah. Of course, you can go to any level of detail in a question like that. But the first few things to think about is the FHIR standard is broad. It really encompasses a full range of clinical and claims data, and it's continuing to expand. But to implement the FHIR standard, you don't have to implement every single thing that's in the standard. So one question is if you are think of it in either direction. If you are building, let's say, the box that I showed, you're the system storing the data. Is the data that you're putting into your FHIR model, FHIR API, the data that the application is expecting? And it works the other way around. If you've built an application to expect certain data, just because someone supports FHIR doesn't mean they've implemented exactly the piece that you're looking for. The standard has a good way for different users to publish electronically. Well, what have I implemented? There's your conformance statement. But it's one of those differences from putting the icon on a system and saying, there, I support FHIR, and being able to practically use it. Have you actually implemented the data that your customers are interested in? I think that's one. Maybe so that I don't go on for too long, the next level thing is, how close is the data that I have today that I want to share via FHIR to the FHIR standard? And I'm thinking things like code sets and terminology services. FHIR offers a lot of flexibility that you can use your own internal or proprietary code sets. National standards are preferred, so are you going to want to or need to map some of your data to national standards if it isn't already, or are you going to be sharing proprietary code sets that your user base may or may not be able to interpret? So some of the data, let's say semantic level interoperability questions, I think come up and should come up when you first consider a FHIR implementation.
Thanks, Mike. Chuck, I just want to circle back with you quickly. So from that perspective, how do you, from a systems wide approach, are confirming that all of the standards and needs are met from what is going to be required? Are there some tests? Should we be looking for something? Tell us from your vantage point what that would look like.
Yeah, there's Helen, there's probably, and Mike could probably speak to it as far better than I. There's I'm sure some much more educated individuals in terms of the individual standards and the requirements associated with the FHIR APIs that have been enabled and will be enabled across all health systems. But I'm not familiar with what those were and how we met those, although I know it required a fair amount of work to make sure that we were able to deliver on that.
Okay, Let's go to, thanks, Chuck.
Yep.
We could circle back with that comment and thought too. Azmat, maybe you could share some insights with Jennifer on the impact to providers and patients from an operational and usability standpoint, and share your insights with that.
Thank you, Helen. Happy to. So picking up on some of the thoughts that have been shared so far, the piece that we often have to reflect on when we are talking about compliance, and also to your question, Helen, about how do we assure that we are compliant with all of these standards. Obviously, this final rule does not land in a blank environment. It lands in an environment where, to quote Jane Austen, it's a truth universally acknowledged that most providers, if you ask them what is the one thing that they would like, first answer is more time with their patients and less time with their electronic health record. So whether it's a psychiatrist in New York, Pennsylvania, or a pediatrician in Seattle, Washington, or anywhere in the country, that is a pain point for providers. So I thought we would reflect on what are the current gaps currently for providers and for provider communities. One of them in relation to the burden, shall we say, that is how they perceive it, of much of the documentation. It does contribute to physician burnout because they want to focus on their patients. They feel that some of this work is perhaps unnecessary. They do and have significant concern about interoperability across the continuum of care. Some of my colleagues have commented on the fact that we don't all have one EHR. We have multiple technologies, and data does not currently flow seamlessly. Processes are not seamless amongst the organizations. We also have data security risks, and clearly, just like with any organizations, we want to take a look at some of these standards that are coming up and the innovation that we hope to generate and see if there are business opportunities that we can take advantage of while reducing our costs. So some of the benefits that we can think about, and certainly I'll ask Jen to chime in shortly, is with regard to what this can deliver to providers. It would allow integration across standard information, would allow us to become more patient-centric, to the point that Chuck made. Perhaps the conversation would be preemptive rather than post. However, many providers have commented when they've been asked, what are the benefits that they've seen on the patient portal? Two areas that they often mention: they appreciate having the ability to write the prescriptions electronically, and they very much appreciate also the fact that they can message patients directly. It saves on their costs for their office staff, it saves on interpretation, and it is a patient satisfier. So certainly that's a benefit, and the more access and the more communication we have between patients and providers, the better we will continue to make the journey to better care. The opportunity to move beyond the EHR, that would be something certainly of benefit once the APIs become standard, and they allow us to create further technologies that would be perhaps more useful to providers and patients. Some of the things that Chuck mentioned, perhaps some of these concepts will come to reality with chronic care patients, where the standard information exchange would allow us to provide yet another interface that's more intimate and more personalized, rather than the general configurations we have with EHRs. Challenges, obviously, patient relationship management. Patients might have questions. They already have such little time with their providers. If they're going to start asking questions about, hey doc, I've got this app, would you please tell me how to do this or that? That takes away from that care time. It also, interestingly enough, one of the providers shared with me, it reduces perhaps in a certain way the confidence of the patient with the provider. The provider may not know. The provider, she was anxious that she may not understand this technology. And yet she is in a position when she's interacting with the patient to provide confidence, to provide support, to provide care. And so she certainly saw that as a challenge in the future as patients interact and ask questions. There's obviously the notion of, once we have all of this data readily available, how does one get to the data that is the most impactful in a quick and easy manner? So I think those apps that come about, that technology that's developed to allow that to happen, is going to be perhaps some of the technology that wins out as we see more development. There's also the notion of data provenance and the standard that's being developed that does require that as part of the data set that gets exchanged. That is actually very good because providers would be able to see where the data is coming from, and that gives them an idea of the significance of the information. It can also be challenging depending on how much depth of information is available there. They may just look at the organization. Well, that doesn't tell them very much about what the information was. And of course, challenges of security risks and supporting the applications. Again, that's going to be something that providers and provider organizations will have to think about. How do they educate their providers? How do they educate their patients about the kinds of risks that might be out there in terms of using such technology, and how do they even assess it? If we can go to the next slide, Nick. A few thoughts with regard to benefits and challenges from patients. We all know that lack of access to information has been a constant theme. Generally speaking, patients those who have utilized the portals, have appreciated having their lab results available and that information, as well as others, readily available to them, such that they don't have to continuously call their providers or their provider offices for interpretation, understanding, etc. However, there is the gap there that they may receive incomplete information. They may get one lab result, but they don't necessarily understand how that works in conjunction of their overall care plan. So with these benefits and real-time access also come those types of challenges. And as I mentioned earlier, data privacy and security is continuing to be of concern for all of us as these technologies move forward. I'd just like to make one more point before I turn it over to Jen. In terms of understanding data privacy and security, both provider organizations as well as patients not only have to understand how their data is going to be utilized by some of these apps that will emerge from this development, but they have to develop a greater understanding also of what happens when errors occur. And I'm not sure that we've made that journey yet as to how those errors would be corrected and what kinds of impacts those may have on future care that's delivered to that patient or provided by that physician. And so there's really real concern out there with providers as to what their liabilities are when all of this information is zipping around in real time. And if there's an error and they made a decision, a clinical decision for a patient, does this increase their liability based on erroneous information? Who will follow that through? Where will that end up? So there are definitely many, many concerns as we move into this area. Certainly, it's very exciting. We hope that we will make this journey into a far more usable and interoperable environment. But there's much work to be done before we realize some of the benefits. So talking about all of that work, I'm going to be turning it over to Jen Bice and gather some thoughts as to the practical programs that are occurring right now.
Hi, everybody. So many of you guys know that achieving compliance is not easy at all. So there's lots of steps to reach that achieving the compliance. So what organizations and healthcare providers need to do is to understand the rule. That's really what everybody should be doing right now if you've not done that. So get out there, Look on onchealthit.com. I think it's .gov actually. The links are at the end of the presentation. Look at that website. Review any webinars that are posted. Sign up for any webinars that are available to you. EHR vendors, we've had a lot of EHR vendor presentations, so reach out to your vendors. And then once you understand the final rule, really building the organizational support, communicating through the organization, and planning is going to be the success for reaching that regulatory compliance. So once you understand it, you really need to start assessing what's going on within your organization already. So what are you currently doing? Are you sending information over to the portal? Are there things that are blocked that go to the portal? Are there things that from a state regulatory you can't send over to the portal? So how will you actually get that information to the patient when they request it? So assessing what you currently do is very, very important at this point. And then identifying the gaps. So you really want to start to look at the gaps in your workflows on how you can achieve this regulatory compliance. And working with your vendors, working with all departments, working with your compliance department, your health information department, your providers, and everybody to find out what you need to do to work towards the compliance of the 21st CARES Act. And most importantly, I'm not a EHR vendor, so I might say this, but the technical part, it's going to be a little bit easy. But the education, as you've heard from everybody else on the panel, is extremely important. Everybody needs to be educated about this. The patients will have their information at their fingertips before their providers do. So the providers, the healthcare workers, the nurse at the bedside, everybody needs to be educated on what the 21st CARES and information blocking means to them and to the patient. And then once you've done all of that work, there's a lot more work to do. So you want to be able to integrate all of the things that you've identified are gaps into your new workflows that will be put in place to be compliant with the 21st CARES. So you'll have to do lots of planning, lots of assessing, updating policies and procedures, and then re-educating everybody again. And then at that point, you can implement these changes into your workflows, into your systems. Okay, I'll turn it back to Helen.
Jennifer, so in your opinion, have you seen a lot of pushback when you're trying to educate, or, you know, squeaky wheels trying to say, oh, this can't be done? Give us your real life drama that you may sometimes see, just to give us a heads up.
Yes, so a lot of concern for patients, and what does this mean to our patients, and are they going to ask lots of questions? Are they going to get diagnosis of cancer prior to a provider calling them and letting them know of that? So really, at this point, the pushback is keep it blocked. So really having to work with people to make them understand and then educate ahead of that patient getting that result. I know Mike and Azmat have already touched on that, and Chuck. It really is a new mindset for everybody in the organization as to how we deliver health information to our patients.
So when you say block the data, is there a time limit that you've seen that people accept and then eventually get agitated that they are not getting that result? So there's a balance act there, for sure.
Yeah, so from a provider, it really is wanting to get ahead of the game and reaching out to their patients ahead of time, and then having the patient have access to the information. But from a patient, they want it now. They don't want to wait. They want to have it immediately. So you have to balance that out. How are they going to have it at their fingertips and still have the provider be able to get the true knowledge of that result to them?
So before we end the panel and open for questions, I want to ask each of the panelists their opinion. Do you think this CARES Act is helpful, a hindrance? Does it add to quality care delivery? Does it tax our technology? So we'll start Azmat, Chuck, Mike, Jennifer, last but not least. Azmat?
Certainly, Helen. I think overall, the vision is absolutely right. And this is the direction that we should be going in terms of allowing patients access to their information and making information exchange more seamless across the board between payers, providers, and healthcare organizations. However, I think that there are many concerns that will come up as we make this journey. So I don't think that in the short term, we're going to have that many wins. I think we will have more bumps in the road than wins in the short to near term.
Thanks, Azmat. Chuck, your thoughts?
Yeah, I think, just maybe drawing on some of the points that were made today, fundamentally information transparency and having patients more engaged in their healthcare will lead to improved patient care. I just don't see how that cannot happen. I also feel that the introduction or the opportunity to develop new tools and applications combined with patients' health information to help them manage their chronic disease and conditions could have a real impact. And we've seen what various fitness and sleep apps have done and how they've impacted consumer behavior. And now applying similar applications to chronic disease management, I just think could have a real impact. So I'm looking forward to this.
Mike, your thoughts?
My thoughts are actually similar. I would take off from where Chuck just ended up. From a pure technology point of view, the kind of technologies that we're talking about here are not unique to healthcare. Other industries, every day we use all kinds of apps that are API based, that are service-oriented architecture and microservices and all that. But you don't even think about it. It feels a little bit new to healthcare, but it's really not new technology. There is also always the risk that technology enables things that nobody wants to do, and those we've all seen dead-end IT projects. Where do I think we might find a good sweet spot between some new technology capabilities and things people really want to do? It's in something that Chuck just mentioned. Wherever we have a case, chronic conditions is maybe a good example where you have a real need, real interest, where providers want to engage patients, to provide them information, to have them do things outside of the encounter setting at home and so forth, and then get information back on how is that going and so forth. Now you're talking about a loop that doesn't work if you can't share data very well. And now you can take advantage of things like a mobile app that captures data. And your doctor probably doesn't ask you very often how many steps you took every day since they last saw you. But they might be interested in things like, hey, over the last month, have you had more trouble getting around and are not as active? They're interested in information rather than all of that raw data. This kind of technology can actually make that a lot easier to do and a lot easier to share and have closed loop patient engagement kind of scenarios. That, I think, will prove to be very productive.
Thanks, Mike. And Jennifer, last but not least, we have a few minutes left, and let us give us your thoughts.
Yes, so to build upon what everybody has said so far, really being able to have that interoperability amongst healthcare facilities and patients to decrease the amount of time to get records back and forth to make informed decisions about care, I think is extremely important. I think that it will take a lot of work to get to that point, as we've all talked about here. But once we're at that point and the information is flowing freely, it will help in everybody's healthcare. It's going to take a lot of time, and it's been with promoting interoperability and meaningful use and all of the other regulatory things that have come along the way. This really is going to open up the doors and have information flow so patients can get access to it, to other healthcare providers getting access to it easier. Remember those paper charts? I remember them. They're hard to manage, just like trying to manage all of these different rules. But I think that this is going in the right direction.
Fantastic. Well, I want to thank our panel on behalf of the Compliance Committee and the State of New York State Chapter HIMSS. Nick, I'm going to pass it on to you. I know we only have a few minutes left, but if anyone asks a question, the panel will surely provide an answer, and we could send you the information. So, Nick?
Okay, I'm going to ask the first question, and Helen, you can then direct it, or a panel member can volunteer. One of the questions was, when you say that patients now have access to data through the application of their choice, does the application of their choice need to have any particular certification? And what should a patient look for in an app to make sure that the app can be maintained in a mandated API format? So I don't know who would like to take a stab at that.
Probably Mike, that's a technology sort of sounding question.
Yeah, so one of the things that I think we'll see is leveraging the FHIR standard. One way that you know that an app would be workable with, let's say, a provider's EMR API, is if it's FHIR compliant and SMART compliant. We didn't actually use that acronym, but briefly, SMART is a way that a system with a FHIR API would be able to launch and interact with your application. So I think things like that will become important. As I mentioned really briefly, I think in some cases, providers and payers are going to want to take a step to do some application testing or certification to help patients with exactly this kind of a choice.
Yeah, Helen, maybe I can build upon that. I think it's important, and this thought is not lost on our compliance colleagues and others that have spent so much time and energy in the past on securing protected health information. We are now enabling patients to move their healthcare information into a space that is not protected by federal privacy laws. So we may enable them to move it, let's say, into Apple Health or Coral Health, but where they take it from there, could go into some other app that may be selling that information or sharing that information. So I think awareness around those application use rights and what individuals, the risk and the reward associated with sharing that information is critically important, because again, they're not covered by the privacy laws and HIPAA laws that we've been compliant with within healthcare for years now.
Right, but I think there is an additional thought there in terms of guiding patients and how patients will know. Yet at the same time, they will often, as customers, perhaps ask their healthcare providers, and healthcare providers and provider organizations have to be cautious about, as we mentioned previously, what they recommend or don't recommend, because they do not want to seem as information blockers either. So I think there is that concern that we all need to be aware of as well.
Okay, well, thanks everyone. I think at this point, we're going to bring the presentation to a close. So I want to thank all the panel members for an absolutely outstanding job. Thank you for donating your time, your energies, and this has been an incredibly informative discussion. Helen, thank you for coordinating this, most appreciative. There were other questions that were posted, and we will collect them, get them to the panelists, and then get back to the individual questionnaires with those responses. So not to worry there. Again, this session was recorded, and it'll be available on our website within a week, and also on YouTube as well. Love to have you as a member if you're not one already. So we do these on a regular basis. Check our website. We have multiple events like this every month. And so I want to wish everyone a great Friday afternoon and a wonderful weekend. And thank you again for attending. It was our honor and pleasure to have you as guests on our event. And to the panelists, thank you again. It was an absolute delight. Take care.
Thank you. Thanks, everyone.
Thank you.
Thank you.